Welcome, everybody, to this teaching session on the 4Ms and the age-friendly health system. To start, if you haven't already done so, please scan the QR code and complete your pretest so that we can make sure you actually learn something from this session. Okay. Right, I'm going to kick off this extravaganza with an introduction to the 4Ms and the age-friendly health system movement, and I'll focus on what's occurred at Baystate and what's happening in Springfield, since that's the area where most of you are currently living. So the goals are for you to think about why we need an age-friendly health system movement, make sure that you can identify the 4 key components, what some of the benefits might be of participating, and think about ways that you may be able to apply some of this information to the older adults that you're caring for. So there's a lot of discussion around the silver tsunami, and aging Americans are going to overwhelm the system. That's the wrong way to think about it, right? The right way to think about it, I think, is exemplified by the photograph of my mother at my daughter's wedding. She was within a month of her death from bladder cancer at that point, but still living life fully. That's the goal, right? So part of the challenge is that although Americans on average are getting older, we don't have rising numbers of expert people trained in the care of older adults. This particular graph shows you that the population's getting older, but the numbers of geriatric doctors are not. And in fact, the same thing would be true for gero nurses, for geriatric social workers, for physical therapists. There just are not enough of the so-called experts to provide the care. So we need to think about how the folks in the front line will be able to do this more effectively. This is another way of showing you the gap, right? The dots are where the geriatric doctors are in the state of Massachusetts, and the darker colors are where there's a higher proportion of older adults with multiple medical problems. So a quick glance shows you that there's a significant mismatch and some disparities around where the care can be accessed. And again, the same thing would be true for other team members as well. Sort of, excuse me, Northwestern Massachusetts is a challenge, as is the area around Springfield, where we all work. Springfield is particularly challenged. Over a third of older adults in Springfield have combined household incomes of less than $20,000 a year. Their health indicators are worse than the state average. Lots of challenges around obesity, depression, memory problems, dementia diagnoses, all much worse than for the state of Massachusetts as a whole. So, not surprising that more older people in Springfield are injured in falls, have difficulty walking, and use the emergency department and hospital more than older adults in the rest of the state. Another challenge that we faced, hold for a sec. Oh, we'll back up to this. Old ladies who can't talk anymore. You think that would be one thing I'd be good at. Okay, we're going to pick up. You ready? Okay. So another challenge is that people who make a study of caring for older people tend to be complexivists by their nature. We make everything a bit more complicated than it maybe necessarily needs to be. And that has made challenging, oh boy. Another challenge is that people who specialize in the care of older adults tend to make things very complex. And that has contributed to making it really challenging for frontline people to practically figure out how to screen for geriatric problems, and intervene on them. So we really needed to figure out ways to simplify and standardize things down so that our primary care physicians, our frontline nurses, our folks working in healthcare would know what was important to assess and how to do it. So there are a lot of reasons why we need to change the way we approach care. You could see the aging population, limited numbers of experts, and unequal access to the expertise that does exist. So this is a situation that fails patients, families, communities, and healthcare workers as well. So, well, I think you all know who Darwin is. Darwin, famous quote is, "It's not the strongest of the species that survive or the most intelligent, it's the ones that adapt to change." And I think you all know that the dodo bird proved unable to do that and is now extinct. So our goal is to not emulate the dodo bird. So these were the factors, or at least some of them, that led to a major shift in the national approach to providing care for older adults. I think probably you do not need to know all the different initials and names of organizations that were involved in restructuring the approach, but it came to a consensus around what's now referred to as the 4 M's. What matters most: medications, mentation or mind, and mobility. And there are a number of geriatrics experts who think that it might be worth including multiple medical problems or multi-complexity as well. So what's the current situation with the age-friendly health system? There are about 3,000 facilities that are participating. Baystate Medical Center and its community health centers were the first ones to be recognized in 2019 at the higher level of committed to care excellence. To become an age-friendly health system, it's helpful to enroll in an action community, which is a series of monthly webinars and supporting resources offered by the Institute for Healthcare Improvement. And then you need to describe how you're going to interpret and screen for problems in the areas of those 4 M's that we just talked about. And then over a period of a few months, you report how many of your older adults have actually received that care. And this is a schematic that demonstrates for you that those kind of 4 key components are related to each other, reinforce each other, and need to be built into kind of a reliable way of providing care that assesses and intervenes on all of those. And over time, you improve how you're doing this and act on any problems that you find. So when Baystate launched on this, our approach was to build a careful community collaboration with a number of community-based organizations and to combine training and workforce development, folks like you, with innovative programs, and to be sure that we also thought about incorporating palliative care principles. We tracked the outcomes, and as you will see today, the emphasis was on interprofessional teams. So today, your speakers include a number of folks from a variety of different backgrounds and professions. We started in the hospital with what's called our ACE program, that stands for Acute Care for Elders. When we started, people were spending too much time in bed. Drug choices were not necessarily targeted to older people, and a gradual improvement process was begun at this point, not quite 10 years ago. We've now got a full unit on the 6th floor. Daily meetings of interprofessional team emphasize the 4 M's. Patients are up and mobilized, and we've had decrease in falls and restraints, decrease in costs, particularly of caring for the most complicated folks. You see some of our team members there and a few of the recognitions listed. The initial days of expansion were rocky. People had a hard time managing to shift to a larger unit with cardiac monitors. There were COVID surges, but we still managed to try to hold on to the key focus on taking care of our patients. The young guy there who's dancing with the old lady was somebody like you. He was PCT, we call him in the hospital, who was a salsa instructor. The old lady was getting agitated and disoriented as night approached, but they knew she loved to dance. So he came and danced with her, and she didn't have any side effects from that, which she probably would have from drugs if those were needed. We also worked, and you see my nurse practitioner partner, Alina Sibley, there to launch a home care program, which was how we managed to move towards a more age-friendly approach in the outpatient setting, and have cared for hundreds of patients since then. In the early years, the average patients were mostly women, high preponderance of people of color, lots of challenges with thinking and memory. Many had fallen in the previous 6 months. And we were able to demonstrate major gains in advanced care planning, a piece of what matters, right? Decreased caregiver stress, that sure matters, patient family satisfaction, and some decrease in visits to the emergency department and hospital. We tied the work to age-friendly and dementia-friendly work in the city, and succeeded in getting the age-friendly recognition for Baystate at the same time as dementia-friendly and age-friendly recognition for the city of Springfield. And that was a pretty nice day and a wonderful party to see some of our team members there. So why think about this when you're taking care of older adults? It's a way of trying to build consistency into your care, identify problems that you might otherwise miss, and a way to tailor what you do so that you can take care of older adults in a more comprehensive and thorough way, in the same way that a pediatrician cares for children in a special way. So if you're a community health worker trying to be age-friendly, what could you do? You could learn about these common problems, and you'll hear some about them later on today, so that you can recognize the problems, counsel families and patients, and report any problems that need further interventions. You can encourage the patients and the families to go to places where they can get age-friendly care. You can talk with them about what matters. You can keep your eyes peeled for any challenges with medications or side effects. And you can intervene in the home or in whatever setting you're working to decrease the risk of falls by adjusting the environment. And you can notice and report any changes in memory or orientation, because the health workers are often the eyes and voices and frontline ears of the team. right? You spend more time with the patients than many of the other folks, and you're going to be able to pick up on a change if you're trained and astute more easily than somebody who may not spend as much time with the patients. So you'll learn more about all of these 4 M's in the coming time. You are a key member of this trekking team, and we have to do more than know what to do, right? We have to actually follow through and find ways that we can do it.
Okay, I think we're ready to roll. My name is Beth Cardillo. I'm one of the social workers for the Baystate House Calls program, and we are going to talk about mentation, also referred to as dementia. We're going to recognize the signs of mild cognitive impairment, dementia, identify supportive needs, and differentiate normal aging versus dementia. And I will have you all convinced that you do not have dementia, that we're just aging normally. So M is for mentation, and we're looking at dementia and depression. So there is an Alzheimer's continuum, right? And the first on that list is a preclinical stage where there aren't any symptoms, but brain changes may have begun, but not enough that you'll notice or anybody will notice. Sometimes this can start happening 20 years before it actually shows, which is a pretty scary thought. And then we have mild cognitive impairment. There are some memory and other cognitive issues that kind of start percolating. They will come out abnormal when formally tested, but the impairment isn't so bad that it gets in the way of your daily functioning. You're still able to drive, you're still able to go to work. It's just kind of little pieces that pop up. And then it can move into dementia, which is memory and other cognitive difficulties that are bad enough to impact your daily life in all facets of your daily life. So when we talk about MCI, we're looking at corroborated complaints of some memory loss or thinking skills other than your memory. You still have the ability to complete your ADLs, which are your activities of daily living, showering, dressing, grooming, and so forth. But your memory may be impaired for your age and the education level that you're at. There may not be a dementia diagnosis, but it is a risk factor for Alzheimer's disease or other dementias. Often it develops into Alzheimer's or other related dementias, but 1/3 may develop Alzheimer's, 1/3 may stay the same, and for whatever reason, 1/3 gets better. So it may just have been a bad day of testing. All right, let's take a look at dementia. Okay, next slide. So dementia is a neuronal loss leading to cognitive deficits. And if you look at that midsection of the brain on the left, looks like half a cauliflower. It's pretty robust. It's in great shape. Your cerebral cortex is intact, your hippocampus. It's a healthy looking brain. There's no deep valleys or ridges, holes or shrinkage. And the other one, not so good. You definitely have shrinkage. The normal brain weighs about 2 pounds. This one is probably a little over a pound. There's enlarged ventricles, and there's extreme shrinkage of the hippocampus. Now, not every brain that has dementia is going to look the same, right? Because it affects different parts of the brain for different people, depending on what pathways they go into. So, do you know how many types of dementia there are? If there's any guesses out there, 10, 25, 50, or 100? And the answer may surprise you. There are over 103 types of dementia. You always hear about Alzheimer's because Alzheimer's accounts for about 60 to 80% of all reported cases. So most people will say, oh, My mother, she doesn't have Alzheimer's, thank God. There seems to be a dirty word associated with Alzheimer's, but that's the one that you hear about the most. What I hear every day from people is, what's the difference between dementia and Alzheimer's? And we're going to talk about that as well. It is not uncommon to have more than one dementia diagnosis. You could have a a double whammy there. You could have Lewy body dementia and Alzheimer's, or Parkinson's disease, Alzheimer's, and Lewy body. So a question to think about is, why is there so much shame associated with Alzheimer's, and more so than other types? And I think it's because we hear more about Alzheimer's, and that's the one that we're more familiar with. And families have a lot of shame talking about dementia. They don't want people to know about it. So in the explanation, what is dementia and what is Alzheimer's? Are they the same? Dementia is the umbrella, and there are 103 different spokes coming out of that umbrella. It's the term for loss of memory and other thinking abilities severe enough to interfere with their daily life. So again, Alzheimer's, one of those spokes, is 60 to 80%. Lewy body dementia is 5 to 10%. Vascular dementia, 5 to 10%. Frontotemporal lobe, which you're hearing a lot now because Bruce Willis was diagnosed with that, is 5 to 10%. And Parkinson's, Huntington's, and other dementias. And we hear a lot about Parkinson's because of Michael J. Fox. And then again, there are mixed dementias. So there are different subtypes of each type of dementia. I'm not going to go through this whole thing, but we know Alzheimer's can last for years, and the most prominent feature is your memory. Vascular dementia is more about, it kind of goes up and down. It's a history of a clinically apparent stroke that's related to cognitive decline. Some days you may do better than others. Dementia with Lewy body is absolutely fascinating. It is parts of the nucleus. It has the protein outside the nucleus of the cell, and it is riddled with a lot of hallucinations early, right in the beginning of a diagnosis. Cognition is fluctuating, and there is muscular rigidity, problems with tremors, and a lot of instability, balance problems. And frontotemporal dementia, disinhibition, apathy, loss of empathy. So not every dementia is alike. The one thing that is alike is that there's no cure, right? So normal aging versus dementia. Everybody starts thinking about, oh, I lose my keys all the time. I can't remember where I put this. I can't remember somebody's name. You walk into the room and you don't remember why you walked in the room. Then you walk out of the room and you walk back in, and then you remember what you were looking for. Those are all normal, right? That happens to all of us. You can't remember, you run into somebody at a context and they look familiar, but you can't remember their name. The difference is, if you lose your key, you will backtrack and find your key. And you'll remember that it dropped in your grocery bag when you were unloading the groceries, and there's the key. Somebody with Alzheimer's may find the key and not even know what the key is for, or why they were even looking for it, because they have no recall that they lost the key. So that is the big difference. So if you all think that you've got dementia, you probably don't. It is the 6th leading cause of death in the United States. More than 5 million people Americans are living with dementia. By 2050, can rise as high as 1 million. And this is quite staggering. Every 66 seconds, someone in the United States develops the disease. And it sure would be nice if we could find the first survivor out there. Okay, so $818 billion cost of dementia, increasing prevalence as our aging population grows. And is that because we're all living longer, or is it just more out there? Incredible stress on families and care partners, which is something that we see all the day, every day. Caregiver burden and burnout. Who's taking care of the family? What happens if something happens to the caregiver? It is a tough illness to deal with, because it doesn't get better and it doesn't go away. So people with dementia are often denied the basic rights and freedoms that are available to others. Sometimes physical and chemical restraints are still used in care homes and acute care settings. So there's something that we really need to keep fighting for, because people are still people, right? One of the things that I think about dementia, regardless of what type of dementia you have, is that everybody still needs a purpose, and we cannot forget people's basic human rights. So only about half of the people with Alzheimer's are diagnosed, and there are a lot of people still walking around that have no idea that they have Alzheimer's. And that's a bit of a scary thought. We know there's some medication out there, but there is no cure for it. All right, so what are the risk factors? So, and we probably can say this about everything, right? Regular exercise, controlling weight, eating healthy, maintaining healthy blood pressure, cholesterol, and blood sugar levels, not smoking, avoiding harmful use of alcohol, and additional risk factors: depression, low educational attainment, social isolation, cognitive inactivity. And we probably can say that also about preventing cancer, right? If we all eat well and exercise, we will do better. There are risk factors, but it doesn't seem to be rhyme or reason why somebody gets it or not. I will say a study did just come out that really validated the use of weight-bearing exercises and diet, that they have empirical evidence now that it does make a difference in staving off Alzheimer's. So our early signs of dementia: some memory changes that disrupt your life, changes or challenges in planning or solving problems, not being able to complete familiar tasks, not being able to do your checkbook anymore, being confused with a place that you've driven to a million times and not being able to get there, trouble understanding images or spatial relationships, not being able to get the right words out in both speaking and writing, misplacing things and losing the ability to retrace their steps, poor judgment, going out in the middle of the winter with just summer clothes on, and withdrawal from work or social activities because you may recognize that there is something going on and you don't want people to know, and changes in your mood or personality. So also inability to interact appropriately, inappropriate clothing, which I just mentioned, not being able to adhere to medications, forgetting medical appointments, recurrent hospital admissions, repeated phone calls, saying the same things over again, withdrawal from usual activities, unsafe driving behaviors, not being able to drive where you normally drive to, and misuse of alcohol or drugs. So sometimes it's not dementia. It could be depression. It could be a medication side effect. It could be hypothyroidism. It could be B12 deficiency. It could be excessive alcohol or substance abuse. And there is type of a dementia called, and I'm not going to remember, is that Jacob-Creutzfeldt's disease? No, I'm sorry, Korsakoff's disease, which is the use of alcohol. So there are also tests that we do to look at people's impairment in their cognition, and very often an attending physician or other healthcare worker will do this test to see if there are some changes. Okay, we can move on. And then we also do a mini cognitive screening test. Are you able to recall 3 items? Are you able to draw a clock? Pretty easy tests to do, right? Medications. So there is no cure. There are some medications that are out there, but they do not stop or reverse the course of dementia. What they may do is slow down the progression. We've had Aricept and Namenda for years, and I can't say that they do a whole lot. They just may stop it down. The earlier, the better in terms of diagnosis. There are some new medications out, but they come with a host of side effects and are incredibly expensive. So we're not there yet. We can get a man to the moon, but we can't cure this one yet. All right, the number of people with dementia is increasing globally. Early diagnosis and communication and support are important. We want individualized dementia care And we want to look at the family partners for possible involvement and support. And just because someone has dementia does not mean they're stupid. They are still in there. They are still who they are. And we need to remember that, right? They are still human beings and they still have a purpose in life. Next, please. So a team approach works the best, whether you have a social worker and a healthcare practitioner and a nurse and a caregiver. We all need to be on the same page in what we're doing in terms of education. Current partner, care partner role, is the home environment safe? What about emotional health, signs of excessive use of substances, financial restrictions, understanding the disease, looking at social support and quality of life? Putting someone in front of the TV does not make it better, right? So we really want to work with people that have dementia. We want them to have joy in their life. And we want the caregiver also to have joy in their life. And that's one of the things that we do in our role in the Baystate House Calls program, is to work with families on educating them. I think that may be it. Oh, we're going to talk now and keep going. Habilitation therapy is what we do to teach people how to work with people with Alzheimer's. And my quick thing is saying they are not able to live in your world, so you will need to live in their world. They are not doing it on purpose. They are not asking you the same question over and over to bother you, to drive you crazy. They don't remember, right? So remember, if they think it's Tuesday and it's Sunday, does it really matter in their life? Does it matter in your life? Probably not. So you're going to need to let go of things and help them find joy in their day, no matter what it is. And we're going to take away the word no, because you will get agitated and they will get agitated. This is the most important quote that I could find. People living with dementia who spend significant amounts of time doing nothing experience more psychiatric symptoms such as anxiety, depression, paranoia, delusions, and hallucinations. So just sitting in front of the TV is not going to cut it. So our job is to help people find out what we can be doing to help people in their lives have a more joyful life. How we communicate with people, using our body language, encouraging the use of gestures, demonstrations, signs, and pictures. It is more important what your body language says than what your words say. So remember that. Always approach from the front, always smile, even with a mask on, identify yourself, use the person's name, be at eye level, use gestures, put your hand on their shoulder, be calm, be gentle and a relaxed tone of voice, and avoid sudden movement so there's no startling. Let's talk delirium versus dementia. Onset, short time versus gradually worsen over time. Dementia is gradual. Delirium is something that just happens. We want to focus or maintain attention significantly compared with delirium versus in early stages of dementia, and symptoms can fluctuate significantly and frequently throughout the day versus people with dementia have better and worse times of their day. Their memory and thinking skills stay at a fairly constant level during the course of the day. And depression. 1 in 10 older adults are receiving care in primary care setting, meeting the criteria for depression. It is treatable. 50% higher healthcare costs than non-depressed peers. Depression diagnosis is highly associated with several medical comorbidities. Very often to have depression and dementia, right? All right, some of our social determinants of health, looking at our income, losses, social isolation, and I'm just going to throw out there, COVID did not help our elderly population at all. The social isolation and loneliness was enough to just have that skyrocket, right? The diagnoses of dementia skyrocketed also after COVID. depressed mood, disturbances to sleep and appetite, fatigue, lack of energy, loss of interest. And some of these same things are the same as in dementia, right? So sometimes it's hard to weed that out. And sometimes it's both. Alternate supports, making sure that our loved ones have meaningful activities, socialization, connecting with spiritual organizations, maybe listening to music, develop a playlist for them so they can hear their favorite music, reminisce with them. Again, not in front of the TV. People with dementia are not stupid. They still are who they are. They can read your body language. They may not know your name, but they know your connection, and they all deserve dignity. And these are my resources. And now I think I am done. So thank you, everyone.
All right, I'm on pause now. Great job, Beth.
Thank you.
You didn't remember you had so many slides, huh? Oh, you're on mute.
Good job, Beth.
Yeah, excellent, excellent.
Thank you very much. I'm glad it's done.
Leah, you let me know when you want me to start recording.
Okay, I was just looking to see if I knew how to do this myself, but I don't.
Okay,
I don't see anything that tells you how to advance the slide.
you just click or you press page down on your keyboard. But it's all right. I think it went fine with me doing it, so we should be okay. Let me
Okay.
get rid of that ringing phone.
All right, here we go.
All right, here we go.
Hi, my name is Leah Stein. I'm a registered nurse with the Baystate House Call program, and my portion is going to be on medications in the older adult. So you can advance, Carla. Some of the things I hope I cover are why medications are part of the 4 M's. What is polypharmacy? Older adults and medications. What is the Beers criteria? Typical medication errors associated with older adults, and perhaps I'll do a case history and question. So why are medications part of the 4 M's? Well, as we age and our bodies change, the chances for side effects from medications increases. As we grow older, we're more likely to develop long-term health conditions that require taking multiple medications. Many older adults also take over-the-counter medications, vitamins, and supplements. That's why we need to focus on the 4 M's. Go ahead. Medications are metabolized differently for an older adult. Older age is associated with increased blood concentration of drugs and altered metabolism, reduced effectiveness, and increased risk of adverse reactions for many medications. Aging can alter what the drug does to the body in response of the body to the drug. This is called pharmacodynamics. Most drugs pass through the liver, which is the primary site of drug metabolism. The liver is affected by the aging process and is less effective in metabolizing medications than the older adult. As the body ages, changes can decrease the body's ability to break down or remove certain medications from the system. This might mean that medications stay in your body longer. Medications can be affected by food, drink, supplements, or herbal products, or the medications that you take. One example of this is grapefruit. If you take grapefruit, it can interfere with the effectiveness of a statin drug for cholesterol. It can cause a higher chance of more severe side effects like muscle pain or joint pain. Alcohol, that can affect the older adult more powerfully, which makes them more likely to have accidents such as falls, fractures, and car crashes. I mention alcohol since prescriptions, over-the-counter medications, and herbal remedies can be dangerous when mixed with alcohol. Now can we go back to the slide that says polypharmacy? Polypharmacy is taking 5 or more medications. I have some statistics from the Loan Institute. where in a press release, they said medication overload will contribute to the premature death of 150,000 older Americans over the next decade and reduce the quality of life for millions more. Every day, 750 older Americans are hospitalized due to serious side effects from one or more medications. 1 in 6 adults, 65 or older, will likely have one or more harmful reactions to a medication. The odds of experiencing a serious adverse reaction to a medication increases 7 to 10% with each additional drug. Yet today, more than 40% of older Americans regularly take 5 or more prescription drugs. Nearly 20% take over 10 medications. And if you include over-the-counter medications, a full 2/3 of older adults 65 or older take 5 or more medications. The more medications you take, the higher the risk of side effects, drug interactions, falls, impairments, hospitalizations, and increased costs. That's why it's important to identify and help reduce the use of medications that are associated with more risks than benefits in older adults. Now we're going to talk about potentially inappropriate medications. The Beers criteria for potentially inappropriate medication use in older adults is also called the Beers criteria or the Beers list. These are guidelines published by the American Geriatric Society for Healthcare Professionals to help improve the safety and prescribing of medications for adults 65 and older. The list provides recommendations for medications that should be avoided in older adults. Prescribers should also use information from the IHI, which was mentioned earlier, I think by maybe Dr. Brennan. It's an independent, not-for-profit organization that works with healthcare professionals. And their goal is to improve care and health for older adults. Let's go to the common PIMS. So we call these PIMS, which is potentially inappropriate medications. Some of them are prescription medications such as opioids, benzodiazepines, which those are medications for anxiety and panic disorders. Antidepressants such as Celexa, Cymbalta, Remeron. Antipsychotics, sliding scale insulin, and PPIs, which are like Prilosec or Protonix. We use the Beers list to offer guidelines of risks versus benefits for the prescriber. For example, if a patient is losing weight, having interrupted sleep cycle, and experiencing depression, the benefits of taking a medication like mirtazapine, which is the antidepressant that you see, might outweigh the risk of taking a medication that has a side effect of being a sedative. We need to consider that when we are gathering information from the patient regarding their list of medications, they might not remember to include over-the-counter medications like antihistamines, NSAIDs like Motrin, ibuprofen, sleeping aids containing diphenhydramine, muscle relaxants. These medications are all included in the Beers list. You also have to take a look at medications which contain anticholinergic properties. Let's go on to the next one. Anticholinergics, some examples are those that treat allergies and diarrhea. Next one. Anticholinergic side effects can be pretty risky because if you look at the slide, most of these side effects can create a risk of falls. Next one. And if you look at some of the over-the-counter medications, if you see like Tylenol PM, the sleeping aid, so you're taking something for pain, but then it's also making you extra sleepy. And then you add that to the 5 or 6 other medications that you have. One can potentiate or make stronger the next medication. And again, you've got a risk for falls. I'm going to go off screen here for a second to talk about medication errors associated with older adults. As many as half of older adults don't follow their healthcare providers' recommendations on how to take their medications. Well, why is this? I mean, it's not like we purposefully forget to take our medications. You could have difficulty reading the directions. Remember, when you get older, your eyesight changes. You can have difficulty understanding or remembering when to take a medication. You can have trouble opening up the container. Just think about child-proof pill bottles. They can be very challenging to open up. There's also financial burden in purchasing the medication. So these are just some of the reasons why our patients don't take medications as they're supposed to. Well, what can we do? How can we help an older adult manage their medications better? You can encourage patients to make a list of all their medications, including the over-the-counter medications that they're taking, herbal remedies, vitamins, and supplements. Also, they can include medications not in pill forms, such as patches, inhalers, creams, injections. The list should include the medication dosages, frequency of use, and what the medications are used for. If you're caring for a patient who's going to a hospital, going to a medical visit, they could even take their pill bottles with them. That way the nurse or the prescriber can see, is the pills in the bottle that it's supposed to be? Are they using a pill bottle that was most recently filled? Or are they taking pills from their most recent refill and putting it in an older bottle? That's a frequent no-no. I think lastly, we're going to go to a case history that I made up. Next. Keep going. Maybe I'm done. I'm done. Well, thank you very much.
No, I'm not ready because Brianna is standing here staring at me. Get out of here. Okay, just somebody say. Hi, my name is Becky, and I am the registered nurse with the Baystate House Calls team. And I'm going to talk about the third M, mobility. Mobility and falls prevention, sorry. So our objectives today are to understand the importance of mobility in an older adult, understand the importance of falls prevention, promote physical activity to preserve independence, and available tools and resources for caregivers and older adults. So we focus on mobility as part of the 4 M's because it's staying active and moving is important to maintain function and ability. So to do what matters most to us. Sorry. All right. So there's spaces in our life, right? And we take for granted what we have, you know, and the places that we can go. And so we look at what space is available to the older adult. So if you think about yourself, we're probably out there at life space number 5, and we're unlimited, and we're free to move about the country and come and go as we please. We don't need any help to get anywhere. But But then maybe we have some fears, or we've fallen, you know, we're afraid of crime, or COVID kept lots of people, limited people. So that would bring you down to a life space number 4. So you're kind of limited about where you're going to be able to go. Your transportation is limited. And then you go, you know, maybe you're homebound, so you can't drive at all. You're able to get out into your yard, and maybe walk down the street, but you can't drive at all anymore. So your spaces become more confined. So you're kind of down to just your home environment. So it kind of makes you a little secluded there. But then when you can't get out of the house, maybe you don't have any, you know, you can't ambulate well, and you can't get down your stairs, or you live on a second floor. So now you're kind of stuck inside the house, and that's at life space number 1, because, you know, you're confined to your house. And then, you know, when you're immobile or bedbound, you don't have any sort of medical equipment, you don't have a walker, you don't have a Hoya lift to get you out of bed, and now you've been limited down to space 0, basically. So our goal is to keep people as close to a 5, if not at a 5, as safely as possible. So some of the priorities what are some of the priorities to maintain mobility, right? We want to recommend grab bars and canes, in a walker if it's necessary. We encourage people to exercise so that they can gain strength and maintain and improve their independence and balance. We provide fall education in the home, because we know that if we can prevent falls, that's really the best defense is to prevent them from even happening. So education is key. Some things with functional fitness that we talk to our patients about: mobility, so standing, walking, propelling a wheelchair, anything that gets you moving. Self-care, so, you know, if you can bathe yourself or dress yourself, and eating, those are things that we do functionally to stay fit. Maintaining a living environment, so preparing your own meals, doing your necessary housework, driving, reaching, lifting. You know, maybe you have something up in the cabinet and you got to reach way up and grab it out of the cabinet. That's all exercise, right? It is keeping you fit. Pursuing your own life interests. You know, I love gardening. This is the perfect time of year to garden. So you're out there gardening, you're caring for your pets, or walking your dog. Maybe you're playing with your grandchildren, or you enjoy pickleball or kayaking. So recreational activities. Mobility in older adults, really we're focusing on improving strength and balance and independence. We know that our core strength is important to maintain our balance. So what are some ways that we can do that? Can you think of any exercises that might strengthen your core to, you know, improve your flexibility and your balance? So just keep that thought in mind. Those who think they have no time for bodily exercise will sooner or later have to find time for illness, which is very true. So these are some exercises. They have lots and lots of benefits, right? So aerobic exercise, like, you know, you can have a stationary bike, or you can march in place. You know, sometimes patients, maybe they can't get up to walk, but they could pedal a bike if they're sitting in their reclining chair. Or they, you know, maybe we always encourage people to stand up once an hour and just march in place, and then sit back down to keep their blood flowing. Flexibility and balance is important. We actually partner with Dartmouth and the Greater Springfield Senior Services, and we have a Tai Chi program that's available over Zoom for our patients. And that is a really great way for them to be able to, gain their strength and have a little bit of that independence to exercise. Benefits of regular exercise. There's so many benefits to exercise, and we all know it, but it's good to have a good reminder. So benefits will, it keeps our older adults active and more independent, and improves their quality of life, right? Because they're not going to be confined to that 0 life space. They may be able to stay out at the 5. It reduces their incidence of chronic diseases. If they could stay active, they might keep their blood pressure down. They might, maybe their diabetes will be under control, which will limit other things. So there's definite benefits to reducing your diseases if you're staying active. Being active, it reduces depression and anxiety. It helps to control weight gain, which will help with your joints. It maintains healthy bones and muscles. Of course, it reduces constipation. People don't realize when they get older, they don't move as much. And when they're not moving, their bowels aren't moving as much, when it causes constipation and dehydration. So those are, things to remember. And it just promotes their psychological well-being. Nobody, sitting in front of a TV, like Beth said earlier, is just not good brain work, right? So it doesn't keep you kind of upbeat and focused. So there's different levels of activities. We're not all marathon runners. I'm not planning on running any marathons, but we all got to start somewhere. So we shouldn't all be couch potatoes either, right? So a light exercise is really what it says. Your heart beats slightly faster. You could still talk and sing. So maybe like a stroll with the dog or just stretching. Moderate exercise is a little bit more vigorous. So your heart rate's up a little bit more. You can talk, but you can't sing because you get a little bit out of breath. So maybe some strength training or a little more faster walk. Even swimming is a good exercise, and it's easy on the joints. Vigorous exercise is, of course, more, right? So your heart rate is increased significantly. You can't talk, or talking is broken with large breaths. So, like if you're on an elliptical or a stair machine, or you're playing racquetball or pickleball. It's recommended that we are getting between 150 to 300 minutes or 2.5 to 5 hours a week of exercise. If you're really in shape and you can, there are the older adults that are out there really kind of getting at it. And then we would recommend that they were exercising it, a little bit more than that. Before COVID, do we remember before COVID? So senior centers, everybody had, yoga and Tai Chi, and they had walking groups and they had dancing groups. Those things are starting to come back a little bit now. We do have, the Raymond Jordan Center in Springfield. They have gym classes. They actually have a gym. It's a beautiful gym for the community. Hungry Hill has line dancing and some more exercise classes. Claro Concepcion has line dancing, a walking club. Riverview has chair dancing. So maybe you can't get up, but you still want to wiggle yourself around a little bit. I'm going to do some chair dancing, preventable healthcare programs, and then fitness centers. So they have cardio machines, weight stacks, classes and strength training. Sorry about that. So these are just some more options for activities for older adults. Their Alzheimer's Association has a list of activities for older adults. You can look online, you can go on YouTube, Silver Sneakers. I know right here locally at oh goodness, is it Health Checks in West Springfield that has the silver? They have a, I think they have a Silver Sneakers program there. So there are places out there in the community. Sometimes it's hard for older adults to find, but one of the things that we do is we help them, right? So we advocate for them and give them the tools that they need to find the resources that they are looking for. So we want to talk about prevention too. So now we know what we can do, that we fall and some of the things about it. So we want to prevent some falls. I'm going to give you some statistics, and I know that sometimes people hear statistics and they kind of shut their brain off. So I've kind of tried to make it a little bit more relatable for us. So in the next 60 seconds, 60 older adults will fall. 36 million older adults fall each year, and 32,000 of them die. 1/5 of falls will have a broken bone. So that translates to 12 out of the 60 people who fell in the last minute. So 3 million are treated in the ER, or 1/3 are hospitalized. So if 3 million people are treated in the ER for falls, that means that 1 million of them are going to be hospitalized. And just a little fact for all the women in the room, women fall more often and account for 3/4 of all hip fractures. So it's something to think about. Make sure you're, checking the osteoporosis and your bone density. So there's consequences of falls, obviously. 25% of all hip fractures will die. So, falls are the leading cause of traumatic brain injury and lead to cognitive decline. Half of the people who survive a hip fracture end up in a long-term care setting for over a year or more. So falls are preventable, and fall deaths are preventable. So here's some of our risk factors. I know I had to look this up. So intrinsic and extrinsic. Intrinsic is things that are out of our control. So things that we don't have any control of how old we are, if we've fallen before, if we have a fear of falling, if we don't have good balance, maybe we're incontinent, or we have, diabetes or Parkinson's. Those would be reasons why, we don't have control of those things, right? So extrinsic risk factors are things that we do have control over, right? They are preventable. So the extrinsic would be, so if you don't have stair rails, you have poor stair design, no grab bars in your bathroom, uneven or slippery surfaces, you don't have good lighting, or there's a glare, improper footwear, we see that a lot, psychoactive medications or alcohol abuse, like Leah was saying. So some things you want to remember is, for these extrinsic, you can prevent them, right? So these are preventable, they're in our control. So you want to make sure you have regular eye exams. If your patient has orthostatic hypotension or is prone to getting dizzy when they stand up too quick, you want to make sure that you're reminding them, get up slowly, take your time, move to the edge of the chair, move your legs around a little bit, get your blood flowing before you stand up, so that you're, hopefully your body can reach that place where it needs to be for your blood pressure, so you don't drop when you stand up. Maybe you've urinary incontinence and it's hard to get up in the middle of the night and run to the bathroom, and that's where grandma's falling, right? So just get her a commode for next to her bed. She doesn't have to use it all the time. You put it next to the bed, she can get up, use the bathroom, keeps her independence, right? Because we want to keep people independent, but then we've taken away that risk of falling. All right, so some more interventions. Okay, so we look at the medical. We're going to reduce medications, manage medical conditions such as hypotension. Like I said, go to the eye doctor, avoid alcohol and substance abuse. And where the right footwear. Just a little side note on footwear and diabetes. Patients who have diabetes often have neuropathy in their feet, so they might not feel their feet like we do, and it's actually like walking on a thick cushion for them, so they don't have a good feel of the ground. So when they can't feel the ground, then they're not steady on their feet. So that's important too, to remember that they're wearing the right shoes and they're secured to their feet properly. Rehab is another intervention that we always look at. So, maybe they have been in the hospital and have been sick and they've deconditioned a little bit. To make sure that they're getting some exercise. We want to give them, to build their strength back up. We're going to work a little bit on their balance and their gait, because we, if their core is nice and strong, then the rest of them should follow along behind. Work with them on strengthening and stretching exercises, yoga, tai chi. I mean, if you can't get out, you can always do yoga on the TV, right? You can find free yoga and stuff like that. And then, a lot of times people are given, so they're a fall risk and they're given a cane or a walker, but nobody's ever shown them how to use it. So if you have a tool that is supposed to help you, but if you're not trained to use it, that puts you at risk for falling. So we want to make sure that people are properly trained and fitted to their medical equipment, like walkers and canes and so forth. So environmental, let's see. Some of the environmental things that we want to consider is maybe in their home, if they have any like throw rugs, or they have maybe it's cluttered, or a lot of older people live in smaller spaces than they're used to, so they've accumulated a lot of things. So you want to make sure that the clutter is picked up and put away, that, maybe that coffee table is pushed over to the side to give you more room to walk through. So things like that, just kind of make sure they have grab bars in their shower, a non-slip pad, a non-slip mat in their tub, and another mat when they step out onto the bathroom floor when their feet are wet. You want to make sure they're stepping onto a non-skid mat on the floor. They have chair lifts to go up and down the stairs. Make sure there's handrails on the stairs to go in and out of the house. So other interventions, like we said, are to reduce medication. So we know that if patients aren't taking, we know if they are taking things like Benadryl and Tylenol PM, or something, maybe a pain medication like an opioid, their cognitive function isn't on point. So they may be a little bit groggy and not as stable on their feet. So that's when we look at the Beers list that Leah was talking about. And we try to look at, medications and say, can we maybe get rid of this medication, or and just kind of try to improve their condition so that we can decrease their risk of falling. If they're drinking alcohol or doing drugs, we want to, strongly encourage them to stop that. We try to get them to the eye doctors to make sure, and they have the correct eyeglasses and prescription. And again, make sure that they're wearing the right footwear. And so we talked about the rehab a little bit already. They do have in-home PT and occupational therapy. Like the Tai Chi program is a great way to get people out and exercising without it being too strenuous on their body and their joints. And so one of the ways that we actually measure is like if a person is a fall risk is steady. So stopping elderly accidents, deaths, and injuries is through the CDC, and they have developed a test with evidence that has to control settings proven effective and translated into practical models that are widely available to community-based organizations. And it offers tools and resources to help healthcare providers screen, assess, and intervene to reduce fall risks. These are some more tools that we give our family members just to jog their memory, you know, kind of one of them, the check for safety has a checklist in it. And we just tell people, go around your home. And, you know, we live in our homes. We don't really think about maybe that rug could trip somebody, you know, we just think it looks good. So it kind of jars their memory a little bit. These are just some different home safety devices. They're also known as durable medical equipment. So handrails in the shower chairs, things like that. And this is just like I said, another checklist for environmental risks that you could look at to, you know, hopefully make it a little safer. Think about outside too, you know, think about the cracks in the sidewalk or the crack in the driveway, or maybe there's a loose stair. Make sure there's enough lighting too, because we want to make sure, you know, we don't see as well at night when we get older. So we want to make sure we can see. This is the checklist that I was telling you about before. These, you know, some of the things, you know, always keep objects off the stairs. I can't tell you how many things are on my stairs right now. Fix loose and uneven steps. What about electrical wires? Do you have a extension cord running across the room to plug in that computer or the TV? Things like that.